So in the previous video we talked about heat stroke causing DIC. And what is DIC? Basically DIC is exposure of tissue factor stimulating the extrinsic pathway and causing formation of clots, and then consumption of too many clots and platelets basically decreases the clotting factors and platelets, and that leads to hemorrhage and bleeding in the body, especially through skin and mucosal surfaces. And this simultaneous clotting and bleeding is basically called DIC, Disseminated Intravascular Coagulation. So in this video we're going to take a moment to basically look at the physiology of coagulation cascade. So quick overview: you have intrinsic pathway and extrinsic pathway, and that leads to, both of these lead to common pathway. So quick detail on that. So factor 12 activates extrinsic pathway. Factor 12 is activated by exposure of collagen following endothelial injury or by platelets, or can also be activated by high molecular weight kininogen and negatively charged glass surfaces as well. So factor 12A and also 2A, and that is thrombin, activates factor 11. 11A activates factor 9. Factor 9A along with factor 8A plus calcium activates factor 10 into factor 10A, and this factor 10A enters from extrinsic pathway that was stimulated by factor 12A into, now we're going into the common pathway we talked about here. This is the common pathway. So factor 10A along with factor 5A with calcium activates factor 2, that is prothrombin, into 2A, that is thrombin. Thrombin, that is factor 2A, activates fibrinogen to fibrin, and that is 1A, and this fibrin basically forms these fibrin monomers basically aggregate and form a meshwork that is stabilized by calcium and factor 13A, and this factor 13 is activated by thrombin as well. So thrombin activates factor 11 right here, factor 8 here, and factor 5 that was in common pathway into factor 11A, factor 8A, and factor 5A respectively. So in extrinsic pathway, pathway you have factor 7 that gets activated to 7A following trauma or exposure of tissue factor. So along with tissue factor and calcium, you have activation of factor 7A that causes the stimulation of extrinsic pathway. 7A plus calcium activates factor 10 to 10A, and as we mentioned that 10A is when we enter common pathway, and then 10A activates 5A, we already talked about right here, and factor 10A plus factor 5A activates prothrombin to thrombin, and this is basically the main coagulation pathway that occurs in DIC. So quick review of intrinsic, extrinsic, and common pathway of coagulation cascade. Anytime you have collagen exposure, high molecular weight kininogen stimulation, and injury, that activates factor 12 to factor 12A. Factor 12A along with and also factor 2A activates factor 11 into 11A. 11A activates factor 9 into 9A. 9A plus 8A plus calcium activates factor 10 into factor 10A, and which goes into the common pathway. Extrinsic pathway gets stimulated when you have tissue factor exposure along with calcium, which activates 7 to 7A. 7A along with calcium activates factor 10 to 10A, and that 10A enters the common pathway. And what is common pathway? 10A plus 5A along with calcium activates prothrombin, that is factor 2, into 2A, and this is thrombin. Thrombin activates 1 to 1A, and fibrin mesh gets stabilized by factor 13A, and recall that factor 13 was activated by factor 2A, that is thrombin. Thrombin activates factor 13 into 13A. Then factor 13A along with calcium basically stabilize that fibrin monomers and aggregates into a clot. So another quick, thrombin activates factor 11, 8, and 5. So anytime you have any factors affected in intrinsic pathway, you will have increased PTT, partial thromboplastin time, and anytime you have extrinsic pathway coagulatory factors affected, you will have increase in prothrombin time. So the way I kind of remember it is extrinsic, you can remember with PT, play tennis. So you play tennis outside, and that's how you can remember that extrinsic pathway is outside, you play tennis outside. And then intrinsic pathway, you can remember it by play table tennis, PTT, play table tennis. You play table tennis indoors. Intrinsic pathway, you measure PTT. So intrinsic with indoors with PTT. So that's a quick coagulation cascade review. And then we're going to talk more about disseminated intravascular coagulation now. We already talked about this, that heat injury stimulates tissue factor on endothelial surfaces. Extrinsic system is activated, and factor 7A gets activated. Increased thrombin production occurs, which activates fibrinogen into fibrin. Clots deposit in microvessels and cause organ failure. Thrombin activates platelets via binding with GP1B, and proteolytic activation of G protein coupled protease activator receptors present on surface of platelets. So GP1B and PAR, these receptors are present on surface of platelets. These GP1B and PAR1 get activated by thrombin, and this stimulates the platelet aggregation and clot formation. And too many clots causes the decrease in platelets, and which leads to thrombocytopenia and increased bleeding. And anytime you have a problem with decrease in platelets, you'll have increased bleeding time. So anytime you have issue with platelets, bleeding time will be affected only. So anticoagulants. So another way you have inactivation of clotting and increased bleeding and hemorrhage is because in DIC you have anticoagulants are decreased. So tissue factor pathway inhibitor, this basically inhibits the tissue factor. So tissue factor pathway inhibitor along with factor 10A inactivate tissue factor and factor 7A. So your extrinsic pathway of coagulation will be affected, and this inactivates clotting. Antithrombin 3 inactivate factor 2A, that is thrombin, and this prevents fibrinogen to be converted to fibrin, and this also decreases clotting. and there's too much, so 83 antithrombin 3 is consumed a lot in DIC. So this basically inactivates thrombin. So thrombin also activates protein C, and remember, recall that protein C is anticoagulatory in nature. It's anticoagulant in nature. So protein C uses cofactor protein S to degrade factors 5A and factor 8A, and this also decreases clotting. So since you have too much production of thrombin in DIC, this activates protein C, and protein C along with protein S degrades factor 5A and 8A, and this basically also decreases the formation of clots. So these are the three ways you have decreased clotting and increased hemorrhage in the body at the time when you have DIC. So another another things that happening is decreased fibrinolysis. You have Plasminogen Activator inhibitor type 1. Basically this inhibits the plasminogen, basically conversion. So plasminogen activator inhibitor is basically anything that activates plasminogen into plasmin. And what are those things? You have TP8, thrombin, and fibrin. These three are basically converting plasminogen into plasmin, and you have too much activity of plasminogen activator inhibitor, and antiplasmin activity is increased. You have too much activity going on for PAI and alpha-2 antiplasmin. So basically plasminogen activator inhibitor basically affects TPA, thrombin, and fibrin, and prevents the conversion of plasminogen to plasmin. And alpha-2 antiplasmin is works against plasmin and prevents the activity of plasmin. So both of these mechanisms decrease the plasmin activity and causes the increased formation of clots, and along with slow clearance of fibrin by plasmin. So since you have decreased activity, your fibrin is going to be slowly degraded, and so increased clot formation, decreased clearance of fibrin, you will have slow degradation of fibrin, and that causes the formation of fibrin degradation products, which are anticoagulant, since FDPs inhibit thrombin and platelets. So fibrin inhibit thrombin and platelets, so these are anticoagulant in nature. However, even though you have increased fibrin degradation products, you have something called fibronectin, which basically clears out FDPs from the body. You have decreased formation of fibronectin in DIC, which basically increase the presence of fibrin degradation products and increase bleeding. So ultimately you have decreased plasmin activity and increased bleeding occurring in this way as well. So lab shows schistocytes. Schistocytes are basically RBCs in half. Clots, every time RBCs are passing by, you have those clots that basically shear RBCs in half, and those RBCs take a helmet shape, and these helmet shaped RBCs are called schistocytes, and this causes hemolytic anemia. You'll also see D dimers detected by ELISA, FDP specific. However, fibrin degradation products are specific for DIC, and also you'll have abnormal PT, PDT, and bleeding time. Consumption of platelets and clotting factors due to increased clot formation and decreased clotting factor that leads to hemorrhage. So this simultaneous clotting and bleeding is basically termed DIC. So another thing that happens is clotting in DIC is clotting also activates kallikrein, kinin, and complement systems. Factor